CT urogram findings, ultrasound findings of different kidney infections, different infections. So first, for the terminologies, okay. So for the reference, Campbell Walsh to 11th edition. And for the image, sorry, Google image search lang yung ginamit natin. Tapos, for the terminologies, so bacteriuria is the presence of bacteria in urine. Your pyuria is the presence of your WBC in your urine. Well, you can also have pyuria without bacteriuria. In this case, you should investigate for TB, stone, or cancer. But if you have bacteriuria without pyuria, there's no need for additional investigation. This might be secondary to just a bacterial colonization without infection. And for your cystitis, it's a triad of your dysuria frequency and urgency with occasional suprapubic pain. For the terminologies again, we have our acute pyelonephritis. Again, this is the triad of your chills, fever, and flank pain accompanied by bacteriuria and pyuria. This is a specific for an acute bacterial infection of the kidney, and usually this is not used if there's no flank pain because your acute pyelonephritis is diagnosed clinically. We also have your chronic pyelonephritis, this shrunken scarred kidney. Later, I will show images of this. This is frequently not associated with UTI, but may be secondary to a post-infectious process. For the UTI types, we have the uncomplicated UTI. Here, the UTI is seen in the structurally and functional normal urinary tract. So this is usually seen in women. But however, if the patient has a urinary tract that is structurally or functionally abnormal, structurally pwedeng by means of benign prostatic hypertrophy, functional kung hindi niya na-avoid ng tama, this is the complicated type of UTI. This is usually seen in men. And the factors that increase the chance of acquiring bacteria and decrease the efficacy of therapy, and the host is usually compromised. And of course, the bacteria has an increased virulence or increased antimicrobial resistance. With regards to relationship, we have different types of UTI. We have a first or isolated infection where the patient has no previous UTI and has one remote infection from a previous UTI. But if you have a recurrent UTI, there are two types. You have an unresolved and a recurrent type. The unresolved, meaning hindi nagresolba, did not respond to antimicrobial therapy. And when documenting it, usually nakikita dito is the same organism with similar resistance profile because in the first place, you didn't eradicate the bacteria in the first place. So for recurrent infection naman, occurs after documented successful resolution of an antecedent infection. So bumabalik lang siya. Okay, there are two types of recurrent infection. Again, for your reinfection, there's a new event associated with reintroduction of bacteria into the urinary tract from the outside, and also your bacterial persistence, also called your relapse. This is caused by the same bacteria re-emerging from a same focus within the urinary tract, such as infectious stone or the prostate. So for patients having staghorn calculus, and then you treat the UTI, eventually nag-sterile yung urine, and then bumalik na naman yung UTI niya. Ito yung isang classic example of your bacterial persistence. So for your prophylaxis naman, we have your antimicrobial prophylaxis. This is the prevention of reinfections of the urinary tract by the administration of antimicrobial drugs. And your surgical antimicrobial prophylaxis, ito usually tinatanong sa exam ng in-service to. Ito yung administration of an agent before and for a limited time. Usually, between 30 to 120 minutes before the procedure, and then for efficacious level na ma-maintain in a limited number of cases, nagbibigay pa sila up to 24 hours at the most post-procedure. Pero pag sinabing surgical antimicrobial prophylaxis, pag sa exam, in service, this is just given before the procedure. Hindi lahat binibigay pati after the procedure. For your antimicrobial suppression naman, this is the prevention of growth of a focus of bacterial persistence that cannot be eradicated. So let's differentiate naman nosocomial versus outpatient UTI. So pag sinabing nosocomial, this is healthcare associated UTI. Ito yung nangyayari sa patient na hospitalized or institutionalized. So kumbaga ang nosocomial is inpatient UTI. So most common cause nito is your CAUTI. CAUTI meaning catheter associated UTI. This is the most common, 80%. ang sabi nila, any catheter left in place for more than 4 days, infected na yung urine mo. Then eventually, pag nag-symptoms ka, that's the point they call it symptomatic UTI na, nosocomial. Typically, this is secondary to your, since inpatient to, typically it's caused by your Pseudomonas and other more antimicrobial resistant strains. Yung outpatient UTIs naman, or domiciliary, this happens in a non-hospitalized or institutionalized patient, outpatient to. Generally caused by common bowel bacteria. Kasi yun, secondary to soilage or other things. Mostly, it's caused by your Enterobacteriaceae or your Enterococcus faecalis. And this, compared to your nosocomial, susceptible sila sa antimicrobial agents. With regards to UTI incidence and epidemiology, the UTI causes significant morbidity but not cause renal damage unless comorbidities are present. With prophylactic antimicrobial therapy, it reduces the morbidity and the time of recurrent bacteriuria, but the risk of recurrence remains the same. So for the pathogenesis, paano ba nagkakaroon ng UTI yung patient? Most common is your ascending route or your retrograde ascent, from down going up. So usually this is from the bowel to urinary tract. Ang malaking factor dito is your introitus and your urothelial mucosa. Increased na nakikita ang UTI na ascending infection pag may soilage ng feces, pag nagsuspermicidal yung babae, or may intermittent catheterization. Ito rin yung most common route for your pyelonephritis. So pag may acute pyelonephritis ka, fever, chills, flank pain, documented UTI, ang isipin nyo kagad, ano most common route ng infection for that is your ascending or your retrograde ascent. And then, kung nagkaroon ka ng pyelonephritis, bakit ba umaakyat yun? Kasi pag nagkaroon ka ng UTI in your bladder, this is cause edema sa bladder mo, luluwag na yun yung UVJ, aakyat yung bacteria. And this is usually caused by your gram-negative bacteria and their endotoxins. And pag pregnancy, syempre may changes. And pag may ureteral obstruction, may changes. Lahat ito have a significant anti-peristaltic effect. Hematogenous also, uncommon to, increased risk if kidney is obstructed, occasionally by S. aureus and rarely Candida fungemia, and lymphatic uncommon. But sabi nila, direct extension can happen. So for the pathogens naman, there are different pathogens, anaerobes, aerobes, and your viral. So facultative anaerobes are the most common cause. E. coli. E. coli ang most common. 90% ng community acquired, 50% ng hospital acquired, and your 70% neto is caused by the uropathogenic E. coli that fall under the B2 class. So tandaan nyo dito, for the in-service is the B2 class and also the sequence type, yung ST131. Baka tanongin yan. This is, ito naman yung special dito sa ST131 E. coli. It is a rapidly emerging cause of multi-drug resistant infection, including UTI. Other pathogens, Proteus, Klebsiella, and E. faecalis, and of course your Staphylococcus saprophyticus seen in reproductive age women, and also other nosocomial infection that can cause these are the E. coli, Klebsiella, and Enterobacter, and the others. So for anaerobes naman, uncommon to. This is usually seen on distal urethra, perineum, and vagina. But we suspect this if kunwari may bladder irritative symptoms and then you check for the microscopy of the urine and you see cocci or gram-negative rods. And then frequently, this can cause suppurative infection. So mga common pathogens dito is your Bacteroides species, including your Fragilis, Fusobacterium, and the likes. Yung Microbacterium TB, I will discuss later. And of course, yung sinabi ko kanina, yung viral cause, adenovirus yung most common cause of hemorrhagic cystitis in children. So tandaan nyo rin ang viral cause ng hemorrhagic cystitis in children. So again, I would go back to your E. coli, the most common nga, nosocomial, and your outpatient UTI. So your uropathogenic E. coli, usually meron itong mga bacterial adherence. Paano ba sila nag-a-adhere yung E. coli? So I will discuss it here. So bacterial adherence to vagina or urothelial epithelial cells is an essential step in the initiation of UTI. So may ine-express ang E. coli natin, yung uropathogenic E. coli na mga bacterial adhesins. This may be fimbrial, meaning may kamay, o kaya yung afimbrial. So for the type 1 mano-sensitive pili, this is usually asked in the in-service exam. I think sa basic twice ko itong na-encounter. So pag mano-sensitive, at tatandaan nyo lang dyan, it's seen in your non-pathogenic and pathogenic UTI, and this is manosensitive. So, pag may manos ka, nagkakaroon ng hemagglutination process. This is a known virulence factor in your type 1 pilated UPEC. Pag nag-adhere siya with this, is there's more bacterial colonization. For your Pili naman, this is your mannose resistant. P has a tropoisomerism to the kidney, and P standing for pyelonephritis. And this is the most pyelonephritogenic stains of UPEC. And your S. Pili sa bladder and kidney. So my suggestion to the residents is just memorize yung itong tatlong to kasi they usually ask the type 1 and the P. Pili. Yung S hindi ko pa na-encounter. So for the vaginal cells naman, this increases your adherence of the pathogenic bacteria, first by demonstrable biologic difference that could be shown in women susceptible to UTI. So your vaginal fluid appears to influence adherence to cell. If the patient has low estrogen, susceptible more for recurrent UTI, as seen in patients na mga postmenopausal. For your bladder cells naman, yung FIMH-mediated binding to the bladder epithelium, this is the initial step in the intricate cascades of events leading to UTI. And also biofilms shield bacteria from environmental challenges such as antimicrobial agents and the host immune response. Mind you, if you have a catheter left in place for more than 4 days, usually may nakikita incrustation sa catheter. This is caused by your biofilms. So kung may biofilm yun, kailangan mo palitan na yung catheter based kay Campbell. Okay. So for your normal flora naman, natural defenses natin, meron tayong mga normal flora. This is found in your introitus, urethra, and paraurethra. Meron tayong lactobacilli, cons na staphylococci, and your corynebacteria, and streptococci that barrier against uropathogenic colonization. Also, ito, favorite na tanongin dito, ano ba yung natural defense natin is frequent urination. If urine support growth for Nephritis bacteria as opposed to fastidious. It inhibits the growth, inhibitory for growth. And if you have a very dilute urine, maganda yon, and high osmolarity with low pH. And also your urine has a TAM horse pulp protein, defensive role by saturating all mannose binding sites of the type 1 pili. So hindi didikit. So tandaan niyo lang din yung uromodulin, which is a TAM horse pulp glycoprotein. So this, masyado itong ito next tayo. For the alteration of host defense mechanisms, if the patient has obstruction, this increases UTI due to the inhibition of normal flow and stasis. If you are vesico-ureteral reflux, gross reflux in UTI usually develop progressive renal damage manifested by renal scarring, proteinuria, renal failure. And of course, the patient has the diabetes mellitus, increase din magkaroon siya ng risk ng infections, which I will explain later. So, for the untreated bacteria in the first trimester in patients na pregnant, there's a substantial increase in the incidence of acute pyelonephritis because half of these women have upper tract bacteriuria. So for patients na pregnant, asymptomatic bacteriuria, always treat. Pag spinal cord injury with high bladder pressure naman, where bacteriuria is most severe and morbid, due to the need for indwelling Foley catheter or CIC or your clean intermittent catheterization, meron din patient na may spinal cord injury na overactive bladder, neurogenic or ureterectasis, you only treat spinal cord injury na UTI if symptomatic. If asymptomatic, usually you don't treat. I will explain later. So for the signs and symptoms, if you have UTI, of course, cystitis ang complaint. There's usually dysuria frequency or urgency. Suprapubic pain and hematuria are less common, and lower tract symptoms are commonly present and usually predate the appearance of upper tract symptoms by several days. So for pyelonephritis, again, it's pure fever, chills, and flank pain. If there's no flank pain, hindi pyelonephritis. So for renal or perirenal abscess naman, usually the patient has a fever, flank mass, maybe tenderness, and sometimes vague in elderly or symptomatic in some patients. So for the diagnosis of UTI, ito yung mga following. So if you have an organism identified by your SPA means your suprapubic aspirate, may nakita kayong organism, and then symptomatic yung patient, UTI yun, basically Campbell. If the patient is catheterized and then symptomatic yung patient, kinatheterize mo, as low as 50,000 CFU per ml, UTI na yun. If clean catch naman, 100,000 CFU per ml. With regards to leukocyte esterase and urinary nitrite, ang tatandaan natin dito, ang sensitive dito is your leukocyte esterase and your specific naman is your urinary nitrite. So you should correlate. And how to reduce contamination? For men, pag circumcised, no preparation. Pag uncircumcised, i-retract mo na yung foreskin, pakita yung glands, soap and water, and then collect. You should collect first ml of urine para may representation daw ng urethra, and yung midstream naman, representative of the bladder. So, catheterization of a male patient for urine culture is not indicated unless the patient cannot urinate. So, kung naka-urinate, pwede na yun. For your prostatic fluid naman, you can do your digital prostatic massage. This is an adjunct in your diagnosis of your prostatitis. So, ang collection nito, collected express prostatic fluid na lagay sa glass slide, and you collect the first 10 ml of voided urine. After, mamassage yung prostate, kukunin mo yung fluid as added to the urethral specimen. For women naman, this is advised to for women to spread the labia, wash and cleanse the periurethral area with moist gauze and collect midstream urine specimen. And you should never use antiseptics kasi this may give false negative result. For your contaminated specimen, kung may nakitang vaginal epithelial cells and lactobacilli, and ang remedy dito, mid-catheterized specimen na lang. So for your suprapubic aspiration, this is highly accurate, although this carries morbidity with clinical usefulness. And this is reserved for patients with spinal cord injury, newborn, or paraplegic, hindi makaihi. Of course, yung mga neurogenic bladder na hindi talaga nakakaihi. So the bladder should puncture is midline between pubic symphysis and umbilicus directly over palpable bladder. The septic technique is usually done, lalagyan muna ng alcohol, inject mo yung needle mo, and then aspirate 5 ml of urine for culture, and then the other 50 ml for centrifugation and urinalysis. And for the microscopic analysis or your urinalysis per se, done ito if symptomatic yung patient. So usually pag presumptive lang diagnosis lang, yung parang gusto mo lang makita, usually dipstick yung ginagawa. And then kung symptomatic na yung patient, usually kailangan may microscopic studies na yan. So you do a urine analysis. So this assess your pyuria and hematuria. And if there's rapid identification of bacteria and WBCs and presumptive diagnosis of UTI. So you need the specimen to be centrifuged 5 minutes for 2,000 RPM. And the sediment of 5 to 10 ml specimen is analyzed. So for microscopic bacteriuria, sabi dito, 10 to the 5 CFU per milliliter of urine or greater is highly specific finding. So if the patient has a positive, meaning UTI sa UA, urinalysis niya, and negative ang urine culture, nakikita to sa mga contaminated specimen. If there's numerous squamous epithelial cells, indicative for preputal, vaginal, or urethral contaminants. If the patient has, on microscopic analysis, pyuria or hematuria, you think of this may be indicative of an inflammatory process. So for your significant pyuria, more than 2 WB
Hello, Sir Sid. Sir Sid, nawala yung sounds. Hello. Hello.
Baka mo nabagal yung net.
Oo.
First time natin dumami ng ganito.
Well, hindi naman yun. Yung sa ano niya yun eh. Ako yung host eh, pero yung yung connection niya siguro sa bahay. Nawala yung video niya rin eh.
Okay natin.
Nakahang si Sid. Nakahang.
At i-text ko lang.
Sinabutayan ni Best siguro.
Baka nandito ba?
Pwede. Naka-disguise. Hindi natin alam kung sino dito.
Butasan ko lang.
Video.
Butasan ko.
Open mga lahat.
About 10 WBCs in an uncentrifuged, unspun specimen. And if you have an absence of pyuria, this should cause the diagnosis of UTI to be questioned until urine culture are available, because usually this is seen in patients with GUTB. They have an abacterial pyuria. And you should also investigate for staghorn calculi and small stones which can produce pyuria with clumps of WBC in the absence of your UTI. So, for your rapid screen, ko na discuss yan. So for positive result analysis, as 10 to the 5 colony forming units per ml, as in for asymptomatic patients, UTI na siya. And for 10 to the 2 CFU per ml, for symptomatic or dysuric patients, UTI na siya. So, for the imaging naman, radiologic studies are usually unnecessarily for most women with GU infections, but it's required for all children with fever persisting for more than 48 hours despite antibiotics. They require bladder and kidney imaging. And also, this is indicated for high-risk patients if the patient has a known calculi, especially if may struvite stones, which can cause recurrent infection, history of GU surgery that predisposed to obstruction, and poor response to antimicrobial agents after 5 to 6 days of therapy. And also patients na diabetic. So for the radiologic studies naman, may determine acute infectious process. So ang usually ginagamit natin is an ultrasound. Useful to for your calculi, hydronephrosis, and if you're thinking of a stone na nakita sa ultrasound, especially if the patient is for investigation further, usually they include the KUB X-ray or single radiograph for calculi to accompany the ultrasound. CT and MRI has a best atomic detail, and also for your VCUG for reflux, and the radionuclide studies for the function naman. For the antimicrobial therapy, efficacy of antimicrobial therapy is critical. It is dependent of antimicrobial levels in urine should be above the minimum inhibitory concentration. And urinary levels are often several hundred times greater than serum levels. It is much important that your urine levels are higher kasi yun ang tinitreat natin, the UTI. However, the patient has febrile UTI na consistent with parenchymal involvement of the kidney and the prostate, that's a time that kailangan mo rin na meron ka rin susceptible din siya na may blood component din yung binibigyan natin antibiotics. So for risk factors for infection are the following. And also this, how if you give for IFC insertion, kailangan ba natin magbigay ng antimicrobial prophylaxis? There's only 1 to 2 chance of healthy domiciliary women for first-time catheterization. Prophylactic administration of medication during catheterization is not generally recommended. However, if it may risk factors yung patient, you can give fluoroquinolone or TMP-SMX. For urodynamics, not recommended na may antibiotics ka. This is only if with more complex clinical history or anatomy, such as men with large post-void residual or patients na may spinal cord injury. If may risk factors, again, you can give fluoroquinolones and TMP-SMX. For your VCUG, only if with risk factors, you give fluoroquinolone and TMP-SMX. For SWAL, URS, PCNL, this is recommended. Kailangan meron kang antimicrobial prophylaxis. For SWAL and URS, usually dinibigay fluoroquinolone and TMP-SMX. For PCNL, cephalosporins and aminoglycosides. And for PCNL, it should be preoperative urine culture na ginagawa, and if test for positive, you should treat it first before doing the surgery. For transrectal ultrasound guided prostate needle biopsy, is also recommended you give fluoroquinolone, pero ngayon we can also give your fosfomycin. For your TURP also, it is recommended to give fluoroquinolones, aminoglycosides, cephalosporins, or your TMP-SMX. For open surgeries or laparoscopic surgeries, antimicrobial prophylaxis is indicated for clean, contaminated, and contaminated wounds. And antimicrobial treatment with an appropriate agent should be instituted for dirty infected wounds. For urinary tract surgery, clean contaminated ito na surgery, so you should give antimicrobial prophylaxis. And for infected urinary tract, this is the contaminated type of surgery. If you have a risk for endocarditis, it is recommended that you give antimicrobial prophylaxis, especially for geotract manipulation, including cystoscopy. Ang principle dito, you should not sterilize the urine to prevent IE. To sterilize urine, hindi mo pine-prevent yung infectious endocarditis. If may patient may prostatic cardiac valve, previous infectious endocarditis, congenital heart disease, cardiac transplant or colonization, kailangan nila magbigay ng antibiotic prophylaxis. For your indwelling or orthotopic hardware, antimicrobial prophylaxis are not recommended. Recommended only ito pag high risk yung patient. Recently inserted implant na within 2 years, or may potential na yung gagawin mong surgery, may seed the joint na may orthotopic hardware like stone manipulation and the like. And if the patient has presence of host risk factors. So ito na yung mga pictures. Sorry for the very wordy lecture a while ago. Pagdating natin kidney infections, mga picture na to. In women, usually post-pubertal, common to sa age na 20 to 40. Ang risk factor dito is syempre reproductive age to. They use spermicides because also of intercourse, also may possibility of a low estrogen pagpa 40 na, and use of an antimicrobial which decrease the normal flora. This facilitates the ascent naman kung nagpo-Foley catheter yung patient, incontinent or may residual urine, facilitate ascent. Yun nga, yung most common route of UTI is ascent or your retrograde ascent. So, ito yun. So, for your clinical presentation patients with uncomplicated cystitis, usually there's dysuria, frequency and or urgency, and sometimes with suprapubic pain, hematuria or foul urine. The probability of cystitis pag may isa dito na sign and symptoms is 50%. Pero pag yung patient nag-complain na may dysuria, frequency, urgency, combine mo lahat yan, you think of an uncomplicated cystitis in women. For acute cystitis naman, in young women, ang most common dito na offending agent is E. coli. 80% of acute cystitis in young women. S. saprophyticus, second most common to. So E. coli pa rin yung sagot natin pag tinanong sa in-service, second most common sa Staph saprophyticus. Other organisms less commonly involved include Klebsiella and Proteus species and Enterococcus. Acute cystitis in men, same as women, E. coli pa rin. And for the laboratory diagnosis of acute cystitis, presumptive is microscopic urinalysis, and you see a microscopic pyuria, bacteriuria, and occasionally hematuria. Indirect dipstick test naman is done pag may positive ka nitrite, you think of bacteria, and your pyuria naman for leukocyte esterase. So for the definitive diagnosis of your UTI, again, sinestress ko to, urine CS na may nakitang 10 to the 2 CFU per ml, plus signs and symptoms. Mind you, when I showed you a while ago, pag 10 symptomatic yung patient, tapos yung urine culture mo yielded 10 to the 2 CFU per ml with signs and symptoms, tawag dito, definitive test yun for your acute cystitis. Tapos doon, for your routine urine CS naman, this is often not necessary for the diagnosis of your acute cystitis. Usually, urinalysis lang with signs and symptoms, you diagnose the patient already with acute cystitis. You do only urine CS if with recent onset of signs and symptoms suggesting acute. Oh shit! Sorry. Wait lang. Wait.
Nagwawala.
Wait lang sir, may technicalities na sandali ah.
Baka may daga.
Inatake,
Hi, sir.
sir.
Si Dr. Abraham. Hi, sir.
Evening, sir.
Inatake si Sir Sid.
Ano nangyari?
Sinugod sa
Ipis.
Pinadala ni
Yan, daga.
So, differentials for acute cystitis are vaginitis, urethritis, or your urethral injury. And the management of this, pag may febrile UTI, usually you only require 7 to 14 days of antibiotics. Pag a febrile cystitis, walang lagnat, may cyst symptoms lang ng suprapubic pain, dysuria, the like, 2 to 4 days sufficient na siya. So for the medications, you can give your nitrofurantoin, prescribed for 5 days. Ang side effect nito commonly is your GI upset. You can also give your TMP or TMP SMX. That's expensive to. You can give your fosfomycin single dose, to yung bagong drug natin ngayon. You can also give fluoroquinolones. But mind you, pag lalaki yung patient, it's recommended 7 days mo bigyan treatment. So for the follow-up, 90% of women will be asymptomatic within 72 hours if given the antimicrobial therapy. Follow-up visit or follow-up urinalysis or urine culture are usually not required in young women who are asymptomatic after therapy. Pero recommended ito for men kasi usually complicated type sila. And then for your urologic evaluation, unnecessarily in women, and unnecessary in young men who respond to therapy. So for the dictum, UTI in most men should be considered complicated unless proven otherwise. So for your complicated cystitis, this is seen in compromised urinary tract or very resistant pathogen. The clinical spectrum includes mild cystitis to life-threatening kidney infections and urosepsis. Pag mild to moderate illness, it can be treated as an outpatient basis with oral fluoroquinolones. If the susceptibility pattern of the pathogen is known, you can give TMP SMX. For severe cases, kailangan mo i-admit yung patient, you give IV antimicrobials are administered, and kailangan mong ma-determine yung susceptibility pattern nito in that institution. Every effort should be made to correct underlying urinary tract abnormalities and treat host factors that exacerbate the infection. So ito na, kidney infection. First is your renal infection, bacterial nephritis. Ang symptoms ng patient dito is an acute fever with chills, may flank pain, indicative na to for renal infection. But these symptoms are usually not specific. Insidious ang onset or non-specific na nagko-complain yung patient na may local systemic symptoms or entirely asymptomatic yung patient. Yung relationship between lab findings and renal infection is usually poor. And the patient, when you examine this, may makikita kayong bacteriuria and pyuria, although they are not predictive of renal infection. Significant renal infection may have sterile urine if obstructed yung kidney. Pwedeng negative yung urine natin, urinalysis and urine culture is obstructed, or infection na nakikita outside the urinary tract. And pathologic and radiologic criteria for diagnosing renal infection may also be misleading. The effect of renal infection or renal function is varied. So for your acute pyelonephritis, in this image we can see the changes of the kidney when you have an acute pyelonephritis. You may have in your kidney, the patient, again, for pyelonephritis, diagnosis is clinical. Usually the patient complains of fever, chills, and flank pain. So pag tawag dito, based on the tawag dito, pathology na nakikita dito, they may be ongoing na pus formation and inflammation inside the kidney. This can also cause scarring of the renal tissue and then indicative na merong infection sa loob ng kidney. So if you examine the kidney sa mga pathologists, they can see linear bands of inflammation from medulla to renal capsule. Mind you, again, I would stress that acute pyelonephritis, the diagnosis is clinical. You don't have to do imaging in the patient, except if the patient is like more than 48 hours ng may lagnat and the likes. Or hindi gumaganda yung presentation ng patient, that's when you do your imaging. The only definitive diagnosis daw ng acute pyelonephritis other than that of the clinical is catheterization, but this is impractical. Again, for the clinical presentation, fever, chills, and flank pain. For the laboratory diagnosis, usually if the patient complains with that, you do your urinalysis. What you will see is WBC with clumps. You can also see rods or change of cocci. And you can see numerous granular leukocyte casts, which are very suggestive. Urine CS is routine and important and usually positive to. And the offending agent is usually E. coli. Again, yun dun sa virulent, bacterial adherence factor, tandaan ninyo, PPLI. P for pyelonephritis, Yan yon. Yung pilay na ginagamit ng E. coli or your UPEC or your uropathogenic E. coli. Other specimen that can cause this are your Proteus, Klebsiella, and the like. Blood CS is not usually routine. You only do it if systemic toxicity na. Mayroon na signs and symptoms na naglalagnat yung pasyente natin requiring hospitalization. And also, you do your blood CS if risk factors katulad ng pregnant patients. Imaging or CT or ultrasound only if unresponsive to therapy after 72 hours or signs and symptoms suggestive of stones or obstruction. CT is better done than your ultrasound if you want to image the patient to know if infection or obstruction yung patient. So for the management, outpatient, you can give parenteral first na ceftriaxone, then you follow it up with your 7 days fluoroquinolones. For uncomplicated infection but very ill, you give your parenteral fluoroquinolones plus aminoglycosides with or without ampicillin or cephalosporin with or without aminoglycosides. For complicated infection or if the patient has risk factors, you hospitalize the patient, give IV fluids, give antipyretics, and kung may obstruction, must be relieved by safest and simplest means. So, pwede mo lagyan ng NT yung patient. Kung obstructed, kuwari ureteral stone. If the antimicrobial, you give your antimicrobial until the patient is clinically stable. Usually 3 days parenteral, pwede na, or until stable yung patient. Then you follow it up with 10 to 14-day oral antibiotic. So for the follow-up, you should repeat your urine CS within 5 to 7 days of treatment and 10 to 14 days after the discontinuation of the antimicrobial agent. Relapse usually seen at around 14 days, at around 10 to 30%. That's why some clinicians give the second 14-day course or 6-week course necessarily. Additional evaluation may also be done like your VCUG for reflux, cystoscopy, and your DMSA, depending on clinical presentation and response to urologic evaluation. So for acute focal or multifocal bacterial nephritis, the image on the right shows the ultrasound findings. Note that there's a longitudinal ultrasound scan na may nakikita tayong low-level internal echo. So yung parang black, which was due to focal bacterial nephritis. It is seen better on your CT scan, yung parang black na yan, yan yon. Focal lang yung infection. So usually, pag acute focal or multifocal bacterial nephritis, hematogenous yung root nito, with multiple areas of suppuration around the areas that are involved. Patient is usually diabetic and septic, and the radiographic diagnosis, CT scan is the imaging of choice. Nakikita natin dito na less nephrographic density than the surrounding normal renal parenchyma. So it appears black. So patient na diabetic, septic, pinascan mo, nakita mo may black na yon, focal yung infection, you think of an acute focal or multifocal bacterial nephritis. And then for the management, you hydrate the patient. Of course, you admit the patient, hydrate the patient, give IV antimicrobials for 7 days, and then 7 days oral. If not, hindi nag-resolve yung patient, you work up muna sa abscess. Kasi pwedeng yung acute focal pa lang na yun, pwede siyang nagsispread, nagiging abscess. And ang isa pang workup mo dito, kasi it appears black or dark you should think of possibility of an obstruction, even a renal cell carcinoma or a renal vein thrombosis. So you work up for it pag hindi gumaganda yung patient. So for your emphysematous pyelonephritis, from the word itself, emphysematous, you think of air. Note that in the first image, ito, sorry, nasan ba yun? This radiographic image, x-ray natin, nakikita ninyo may air pocket dito. Hindi naman siya Magen-Blasi na nasa taas. Mukhang nasa kidney. So you think of an air inside the kidney. This is better enhanced on the CT scan on your the right. You can see pockets na meron talagang air sa loob. When you see this, you think of an emphysematous process on the kidney. This is a urologic emergency. 60% ng patient na meron ganito, possible na mamatay. This is an acute necrotizing parenchymal and perirenal infection by gas-forming uropathogen. So gas-forming causes the gas inside the kidney. The clinical presentation, again, like your acute for most patients na may sakit, diabetic. high glucose is usually a substrate. And the E. coli produce this CO2 or your air via fermentation of the glucose substrate. And the patient usually has an obstruction. Pwedeng may calculi dun sa kidney na nag-obstruct, which may cause which may cause renal function impairment. And yung triad ng patient dito, may fever yung patient, nagva-vomiting na nagpa-flank pain. Although this is not specific, non-specific naman siya. And the most common offending bacteria here is your E. coli, followed by your Klebsiella, and then your Proteus. So again, this is the image. This is the image. You can see the air on your KUB X-ray, and also the arrows representing a coronal image of your CT scan. You can also see air inside. So this is a urologic emergency. So management. You give first, admit the patient, you give fluid resuscitation, IV hydration, antipyretics, you give a broad spectrum antimicrobial agents. If you see that there's an obstruction, maybe a stone, or if walang stone, pwedeng stricture kung post-GU surgery in patient, unobstruct first, then determine function. And then, if the patient has a functioning kidney, you do medical therapy first. You only do nephrectomy if hindi nag-i-improve yung patient. Pero kung definitely kung hindi na nagpa-function yung kidney, and then suitable naman that he has or she has a contralateral normal kidney, then you can do nephrectomy. Since this is a urologic emergency, the patient may die kasi septic siya masyado. So your perirenal abscess. In this image, we can see that the kidney is squeezed. Sorry. Wait. Sorry, hindi pala ito yung isa. So this image, you can see that the kidney, inside the kidney, there's a abscess or this black colored here on your axial image of your of the CT scan as compared to the normal. So this is a collection of your purulent material confined to the renal parenchyma. Previously, ang sabi nila gram-positive daw yung offending agent dito. Pero currently, gram-negative by ascending infection with tubular obstruction. The patient has a fever, chills, and abdominal pain or flank pain with occasional weight loss and malaise. Usually, you think of a gram-positive pag yung mga patient IV drug users or your multiple carbuncles. Nagkakaroon daw ito ng hematogenous dissemination to the kidney. Parang yung sa, huwag na natin i-discuss yan. Yung saan ba yan? RHD ba yan? Rheumatic heart disease, I think. And then for the gram-negative, this is consistent with UTI or pyelonephritis. And the risk factors include the patient diabetic, pregnant, with calculi or stasis. You think again possibility, gram-negative offending agent. So again, this is image of your renal abscess. Ito naman is pockets ng renal abscess. Yung kanina, focal na isang malaki. Ito, pockets na iba-ibang parts ng kidney natin. So for the laboratory diagnosis, usually, if the patient has a CBC done, marked leukocytosis, again, for your gram-positive, usually this is blood-borne. Ito yung nakikita sa mga IV drug users. They may have a negative urine CS. If you do ultrasound, you can see an echo-free or low echo space occupying lesion with increased transmission. For your CT scan naman, this is the imaging of choice for acute abscesses. Delineate na maganda yung borders, well-defined yung borders. Pero pag pag chronic na abscess, nagkakaroon ng obliteration of adjacent tissue planes. So for the management, pag less than 3 cm, IV antibiotics plus observation. Pag 3 to 5, IV antibiotics. Serial radiographic monitoring. Panagpamasin yung nag-increase ng size, you can place a percutaneous drain. Pag more than 5 cms, IV antibiotics plus percutaneous drain. Pag hindi pa rin nare-resolve, you can do a possible multiple drain. Pag hindi pa rin nagre-resolve, pangit pa rin yung patient, marked leukocytosis, nilalagnat pa rin, possible surgery with contralateral normal kidney, you can do a possible nephrectomy on that side of the kidney. So for your infected hydronephrosis and pyelonephrosis, so in this image, we can see a DJ stent in place. Maybe this is left neglected or maybe neglected stent, and then possible na nagkaroon na siya ng infected hydronephrosis. So there's a suppurative destruction of the kidney parenchyma. There's total or nearly total loss of renal function. The patient presents with very ill, mataas yung lagnat, nag-chills, flank pain, tenderness, na may history ng calculi infection of surgery. In this case, previous surgery na may stent. Bacteria may be absent or if the patient is completely obstructed, kung may ureteral stone na completely obstructed, pwedeng negative yung makikita nating findings sa analysis natin. For the radiographic findings, you see a dilated pelviocalicial system, thinned out cortex and medulla, and there's focal areas of decreased echogenicity with hydronephrotic parenchyma. So for the management neto, IV antibiotics and of course, drainage. Drainage, ureteral catheter, pwede ka magkaroon ng nag-DJ stent insertion, pwede ka mag-percutaneous nephrostomy. Between the two, ano mas maganda, pareho daw siya. Then you determine the function. Once you determine the function, if hemodynamically stable yung patient, you may proceed to treat the source of obstruction if functioning pa yung kidney. If not, you can think of doing a nephrectomy on the patient. So for perinephric abscess, ito naman yung abscess na nasa labas ng kidney ito. Yan. So for this axial image, we can see that there's a collection of fluid outside the kidney. So the greatest obstacle in this disease is the delay in diagnosis. Ang cause ng perinephric abscess is a rupture of an acute cortical abscess into the perinephric parenchyma. May also be secondary to hematogenous seeding from sites of infection. 1/3 of cases, usually skin infection. So again, sa mga IV drug users. This may also be secondary from an infective perirenal hematoma na nag-infect. And then may also be from bowel perforation, Crohn's disease, spread of osteomyelitis from the thoracolumbar spines. And the most common offending agent is the E. coli, followed by your Proteus and your Staphylococcus aureus. The clinical presentation is usually insidious. Usually, this is together with the renal abscess. Symptoms that are usually seen for more than 5 days are abdominal mass in half the cases with CVA tenderness. However, typically, the patient does not respond to 4 to 5 days of antibiotics like pyelonephritis. And you should have a high index of suspicion if yung patient presenting na may UTI, pina-imaging mo, UTI, nag-treat ka, in-admit mo, hindi gumaganda yung patient. You image the patient. May nakita kang susceptibility na parang mukhang mass yung nakikita mo. And then nag-fever. You don't only think of pwedeng renal cell carcinoma or different type ng renal cell carcinoma, renal vein thrombosis. You also think of a perinephric abscess. Radiographic imaging of choice is still CT scan because you can see the abscess with extension to the flank or the psoas. So this image, we can see that there's already an extension of your perirenal abscess. Extend na siya pa anterior. And mind you, when you see this, parang meron na rin siyang fistulization na nangyayari sa skin. So baka meron na tong fistulous tract here. So insidious onset. So think of prompt drainage on this patient. So for the management naman, IV antibiotics immediately to control sepsis. Usually give an aminoglycoside plus anti-staphylococcal because you think of a gram-positive hematogenous dissemination that caused the perineal abscess. You treat this like an abscess. This is based on size. Pag less than 3, antibiotics, possible drainage. 3 to 5, increases size, IV antibiotics, drainage. And then pag more than 5, increases in size, septic, possible drainage, multiple drainage, or nephrectomy. If kidney is non-functioning or severely infected after you place the drain, you can do a nephrectomy on the patient already if this is non-functioning. So for the pyelonephritis, ang pag-usapan naman dito is the chronic pyelonephritis. So pag chronic pyelonephritis, this happens without an underlying renal or urinary tract disease. Chronic pyelonephritis secondary to UTI is a rare disease. And more rare cause of the chronic pyelonephritis is chronic renal failure seen in dialysis patients. The clinical presentation, asymptomatic yung patient until it produces insufficiency. Pero for some patients, symptomatic to pag nanggaling siya sa acute pyelonephritis. So recurrent bouts of your acute pyelonephritis may lead to chronic pyelonephritis. Pero usually, ang cause ng chronic pyelonephritis, yung patient, walang underlying renal or urinary tract disease. Kasi sa acute pyelonephritis, meron kang underlying renal or urinary tract disease. The diagnosis is radiographic. You can see asymmetry or irregularity of outlines of your kidney with blunting and dilatation of one or more calyces, and of course, a cortical scar. So for the pathology, you can see a contracted scarred kidney. And for the management, treat infection if present. You give a prolonged antimicrobial therapy. And yung dictum dito, kailangan mo ma-prevent yung future infections. Kasi if you have a chronic pyelonephritis, you don't treat the UTI, hindi na-resolve ito, it may cause damage to the kidney, leading to a scar, leading to more problems, and decrease in your renal function. So for your Santo granulomatous pyelonephritis, mind you, pag napapansin niyo, in this coronal image, you can see that this kidney looks like a bear's paw. Usually, nakikita tong Santo granulomatous pyelonephritis sa patient na may obstructing stone. Pelvic stone, obstructing staghorn stone, or obstructing ureteral stone. And then nagkakaroon ng dilation na ganito. This is a rare, severe chronic renal infection resulting into diffuse renal destruction. This is usually unilateral, and yung part na kidney na affected is non-functioning because this is usually secondary to obstructive uropathy, secondary to a obstructing stone. This is always unilateral, kaya hindi nagkakaroon ng azotemia yung patient kasi nagkakaroon ng contralateral compensation ng kabilang kidney. The characteristic nito, if you do nephrectomy, you can see lipid-laden foamy macrophages. Tandaan nyo to, malabas sa in-service. It begins with the pelvicoaxial system. It extends and destroys the parenchyma and the adjacent tissues. And usually, this is confused with your clear cell carcinoma of the kidney. So, the pathogenesis, if nephrolith may stone yung patient, may obstruction, infection, you see bear's paw sign on your CT scan, you think of Santo granulomatous pyelonephritis. The obstruction is followed by infection and accumulation of your macrophages, which they call as xanthoma cells. So the pathology, kidney is massively enlarged with normal contour and the calyces are dilated, filled with purulent material. The clinical presentation suspected ito if the patient has UTI, unilaterally enlarged, non or fully functioning kidney with a stone or a mass, and the lesion is usually indistinguishable from a malignant tumor. The patient complains of flank pain, fever, chills, and persistent bacteriuria. And some patients also complain of flank mass and previous calculi naman sa patient. And again, like most of the kidney infections that I have discussed, this is increased prevalence in diabetics. So if there's one disease entity or comorbidity na tinanong, diabetes ang sasagot natin for kidney infection. So yun yung most common. For the laboratory diagnosis, most common offending agent naman dito as compared sa mga previous na diniscuss natin na E. coli, Proteus to. But E. coli comes second. 10% naman sa iba with mixed infection. The radiographic diagnosis, again, CT scan is your imaging of choice, and the classic triad is seen. Usually, unilateral renal enlargement with patient has little or no function, with large calculus on the renal pelvis, maybe a pelvic stone, ureteral stone, or a obstructing staghorn stone. And ang nakita ninyo sa CT scan or radiographic imaging ninyo is a large reniform mass with the renal pelvis tightly surrounding a central calcification but without pelvic dilatation. So again, here in this axial image, you can see again the stone, maybe a pelvic stone, extending here, and then bear's paw sign. Ito yung bear's paw sign. Yan, bear's paw sign. Yan. Okay, pag tinanong bear's paw sign in CT scan, you think of Santo granulomatous pyelonephritis. So for the management, primarily obstacle for treatment is incorrect diagnosis. So for preoperative, bago nyo operan yung patient ninyo, you should have a long-term antimicrobial therapy to eradicate infection and possible to restore function. Pero pag hindi na nag-function yung patient, nephrectomy. Nephrectomy, why? Because yung mass is usually ang isipin ninyo possible na it represents a renal mass. So you do a nephrectomy. But if the patient presents with a localized type of this Santo granulomatous pyelonephritis, you can do partial nephrectomy. So after the surgery, this is difficult to differentiate from clear cell based on frozen section. And your Santogranulomatous Pyelonephritis associated with RCC, papillary transitional carcinoma of the pelvis and bladder, and infiltrating SCC of the pelvis. If malignant tumor cannot be excluded, ineffect nyo na yung patient. So if the patient presents with this, bears po sign, unilateral enlarged mass, septic patient, diabetic, you think Santogranulomatous Pyelonephritis to, na mukha din malignant tumor, better that you do a nephrectomy on the patient. So next, malakoplakia. So for your malakoplakia naman, ito, ang tatandaan nyo lang dito is the Michaelis-Guttman bodies. Ayan. Yung unusual inflammatory disease originally affects the bladder. So most likely sa bladder to, hindi usually common sa kidney. And the histiocytes contain Michaelis-Guttman bodies. These are distinct basophilic lysosomal inclusion bodies with abnormal macrophage function in response to infection. Ito naman, etiology like the others is E. coli. Pathogenesis, usually patient is immunodeficient or may autoimmune disease or cancer. Coliform infections are usually, pag may patient din may coliform infections and compromised cell status, increased risk na magkaroon din ng malakoplakia. Bacteria and bacterial fragments form nidus for calcium phosphate crystals which laminate the Michaelis-Guttman bodies. So ito yung Michaelis-Guttman bodies, yung blue. So pathology na yan. So the clinical presentation, usually matanda yung patient, more than 50. Usually female yung patient na immunodeficient or may autoimmune disease, may cancer, or compromised yung health status. If you do radiographic imaging, you see a multifocal malakoplakia on excretory urography. You can see enlarged kidney with multiple filling defects. Pag unifocal malakoplakia naman, non-calcified mass, indistinguishable from other inflammatory neoplastic lesions. Usually the patient has no calcification, lithiasis, or hydronephrosis compared to that of your infected Santogranulomatous Pyelonephritis, infected pyelonephrosis, and the others. The management for your malakoplakia is to control the UTI, to stabilize the disease process, and usually long-term dapat binibigay. Surgery if the disease progresses, and nephrectomy for symptomatic unilateral lesions, and prognosis dependent on the extent of the disease. So for renal echinococcus, pansinin niyo, these are cysts inside the kidney. You can see cysts inside the kidney. This is an MRI, actual MRI of the renal echinococcus. You can see that there are cysts inside the kidney. So this is a parasitic infection caused by larval stage of the tapeworm Echinococcus granulosus. The pathology nito, adult form ng Echinococcus granulosus would reside to the intestine of the dog, which is the definitive host. And then, pag yung dog dumumi, na-contaminate yung grass, or farm, na-ingest ng human, pwedeng ma-ingest yung larval form nito, didikit sa duodenum, pupunta sa blood, pupunta sa blood natin. Possible hematogenous dissemination going to the liver, lungs, and the kidney. Then there's vesicalization of larva results into the hydatid cyst inside the kidney. So an echinococcus cyst of the kidney is usually single and usually located at the cortex. Single na malaki, located at the cortex. So this is slowly growing tumor, mostly asymptomatic in patient, or the patient may complain of flank mass if this is big, dull pain also, or hematuria. Usually the focal type does not affect the function. Pero kung malaking type na siya, it can affect the function. For your laboratory diagnosis, the definitive diagnosis is cyst rupture and identification of daughter cyst in urine or by identifying laminated wall of the cyst. Less than 50% ng patient with you would see eosinophilia on your blood picture. For your radiologic, there's usually a thick-walled cystic mass, occasionally calcified, with discrete round daughter cyst and a well-defined enhancing membrane. Diagnostic aspiration should not be performed. Kasi pag pinuncture mo yung cyst na yan at lumabas yung fluid, highly antigenic yan, pwedeng mamatay yung patient due to anaphylaxis. So this is the, again, this is the renal echinococcosis. Renal echinococcosis cortex, single, big. Ito na yun. Management, usually good the prognosis, depends on the size and the site of the cyst. Surgery is the mainstay of treatment, but you should remove the cyst na hindi siya nag-rupture kasi it may seed, it can have an antigen reaction, and or it may recur. If the cyst ruptures or cannot be removed by and marsupialization is required, the content should be aspirated and lalagyan mo ng scolicidal agent. Pwedeng sodium chloride, silver nitrate, formalin, iodine for 5 minutes. So bacteriuria in pregnancy. So ito, tatandaan natin. If the patient is pregnant with asymptomatic bacteriuria, treat. So asymptomatic bacteriuria is common in pregnancy. It is reflex situation before conception. Unlike the non-pregnant, spontaneous resolution of bacteria in pregnancy is unlikely unless treated. So, ang tatandaan natin dito, tinanong to sa exam namin dati, ilan % chance na magkakaroon ka ng pyelonephritis for an untreated bacteriuria in a pregnant? 20 to 40%. Yeah, tinanong yan. So, 70% of patients usually have a pyelonephritis during the 3rd trimester because hydronephrosis and stasis is most pronounced. Because the gravid uterus has different effects on the GU system. Treatment of screening bacterial pregnancy decreases the incidence of acute pyelonephritis. So, asymptomatic bacteriuria in pregnancy, treat. So, for the pathogenesis, again, yung gravid state, nag-alter ng tawag dito, no? GU system. Basahin nyo na lang to. I already gave the residents my handout. For bacteriuria complications, it may lead to prematurity and prenatal mortality. Asymptomatic bacteriuria, merong higher risk ang mga pregnant na mag-develop na to na maging symptomatic UTI. Pag ito, adverse fetal sequela to. So you should treat asymptomatic bacteria in pregnancy. UTI can lead to pyelonephritis, can lead to sepsis. Also, this can also lead to maternal anemia. For the laboratory diagnosis, you should have an initial screening for urine CS. So lahat naman ng pregnant patients nagpapa-urine CS during the 1st trimester. Kung may nakita silang UTI doon, tinitreat nila usually yan. Tinitreat nila dapat. If no growth yung urine CS early in the pregnancy, there's an unlikely chance na magka-develop ng bacteriuria later. For positive culture, usually ang pathogen nito similar to non-pregnant patients. So E. coli, Staph saprobiticus. So treatment for UTI, aminopedicillins and cephalosporins, ito yung pwede sa pregnant. Nitrofurantoin if without G6PD in patient or kung may allergy sa penicillin, you give the patient 3 to 7 days full treatment of your antibiotics. If the patient already has pyelonephritis due to possible untreated asymptomatic bacteriuria, you hospitalize the pregnant woman, treat initially with parenteral antimicrobials, and usually more than 95% nagre-respond within 24 hours. So for the follow-up, culture should be obtained to document absence of infection. And these are the drugs that are relatively contraindicated during pregnancy. So pregnancy in women with renal insufficiency. Current management of recurrent UTIs, infections alone, are no contraindications to pregnancy. So pwede silang mag-conceive. But need to evaluate serum creatinine and creatinine clearance before pregnancy. Normal pregnancy is rare pag yung preconception serum crea exceeds 3 milligrams per dl, about 30 milliliters per minute clearance. The major determinant for pregnancy outcome is the degree of renal function impairment. More renal function impairment, the poorer the outcome of pregnancy. So bacteriuria in elderly. This is very common in both elderly women and men. Screening is not recommended, unlike pregnant. There's no relationship between asymptomatic bacteriuria, uncomplicated UTIs, and a deteriorating renal function. So, comparing this to pregnant patient, you should not treat asymptomatic bacteriuria in the elderly. Infections of the urinary tract may present subtle signs, and high index of suspicion is often required for the diagnosis. So the treatment of symptomatic UTI usually requires modification for physiologic and pathophysiologic conditions of the elderly. Patients with lower urinary tract symptoms, you treat pag symptomatic na, ito yung lang i-treat natin. Usually treat it with 7 days antibiotics. Pag more severe or systemic infection, usually give 10 to 14 days. The primary goal in this population, sa elderly, is to only eliminate symptoms and not to sterilize urine. Okay, so you do not treat asymptomatic bacteriuria in elderly. You treat symptomatic bacteriuria in elderly, and your goal is to eliminate symptoms, hindi yung sterilize yung urine. Kasi yung usually ibang patient dito, mayroon ng iba pang anatomical problems that cause already your UTI. Like low estrogen, pwede functional, pwede rin yung patient has a BPH na hindi pa makapag-surgery, mga ganun, and the like. So this is the end of the first part. Meron second part. Sobrang haba nito.
STD ba yung second part?
Ha? Ito na yung second part. Okay, for your catheter-associated UTI, also known as your CAUTI, this is the most common hospital-acquired infection and the most common nosocomial infection affecting children. Bacteriuria with IFC is inevitable kahit CIC lang yan. These factors dito, if matagal na yung Foley catheter ng patient, matagal na siya nagsi-CIC, pag babae, pag mali ang catheter care, gumagamit ng tawag dito, antimicrobials, systemic and unsystemic antimicrobial agents. Most patients na may catheter-associated UTI are usually asymptomatic. And most common route is periurethral and also intraluminal. Pwedeng na-inoculate siya or via the urine bag. And again, catheter incrustation, this is by biofilm formation. So pag may catheter incrustation, this is a telltale sign that you should change the Foley catheter. Infection ka, siyempre immunity compromised ka, increased risk. And all persons with gonorrhea should be tested for other STDs. Treatment, you do treat gonococcal urethritis with treatment of the non-gonococcal urethritis because of high rate of complication. You may give the following: Septri plus Azit or Doxy twice a day for 7 days. You eradicate the chlamydia and the gonococcal. So, ang non-gonococcal naman, ang most common nito is Chlamydia trachomatis. Pero mind you, may iba pa nagkakos ng non-gonococcal urethritis, which are your Mycoplasma genitalium, Trichomonas vaginalis, and adenovirus, and also your HSV1. So, chlamydia is the most common STD transmitted, and usually the patient are symptomatic. So, for the others, pag Mycoplasma genitalium or ureaplasma, symptomatic din yung patient dito, complaints of urethritis, and culture is difficult. PCR ang ginagamit nila for diagnosis but not readily available. So Trichomonas vaginalis also may cause your non-gonococcal urethritis. This is a common bacterial vaginal pathogen, but this can cause urethritis in men. So treatment for NGU, Azit 1 gram orally, a single dose, or Doxy 100 BID for 7 days. So these are the alternative medications. So for the epididymitis, it is the pain and swelling and inflammation of the epididymis that lasts less than 6 weeks. The testis is usually involved, and among sexually active men less than 35 years old, the common offending agents are your Chlamydia trachomatis and your Neisseria gonorrhea, yung cause ng GU at NGU. Pag more than 35 years old naman, usually STD is uncommon daw. An infective organism is usually associated with bacterial obstruction, BPH, with E. coli being the most common. Tumatanda yung patient. Pag hindi na siguro masyado nakikipagtali. Anal intercourse, E. coli and Pseudomonas ang offending agent, and HIV naman for the following. Diagnosis, you do gram stain of your urethral secretions for urethritis. A urine drop dip S-rays on first void urine, and you do microscopic examination of the first voided urine, demonstrating more than 10 WBCs per high power field. Scrotal ultrasound is helpful but not diagnosis. You treat acute epididymitis by giving Septri plus Doxy, BID 10 days. If suspected enteric organism, you give Septri plus Levox milligram orally twice a day for 10 days. So for genital ulcers, ito yung mga most common lang. Genital ulcer syphilis is caused by Treponema pallidum. Transmission nito is secondary to sexual intercourse or skin microablation. The incubation period is 2 to 3 weeks. So primary syphilis, ito yung ulcer itself. Primary syphilis, ulcer. So usually, it occurs at the site of infection. Kung saan yung Treponema pallidum. It affects the glans, corona, or the perineum in men. Labia or perineal din sa women. Ang tatandaan nyo dito, itong ulcer ng primary syphilis ay painless. Indurated, clean ang base, and usually singular. However, in this image, we can see hindi singular. Then, wala kayong bibigay, it would heal spontaneously after 3 to 8 weeks. And then yung patient also has a lymphadenopathy, inguinal. Usually, this is non-tender, rubbery, non-suppurative, and usually bilateral. So tatandaan natin primary syphilis, painless ulcer with non-tender lymphadenopathy na usually non-suppurative and bilateral. Secondary syphilis, nagkakaroon na siya ng rashes, then it may lead to vasculitis and maybe neurosyphilis. And then ang tertiary syphilis, ito na yung neurosyphilis, cardiosyphilis, or gumatosyphilis. Pero sa atin, in our case, we really need to know that kung ganito yung nakikita natin picture, we think of a syphilis. Diagnosis, dark field microscopy remains the gold standard. Pero you can also do your serology. You can do your non-treponemal test. Pag antibody ang minimeasure, meron tayong dalawang test dyan, yung RPR at VDRL. Pag positive ang antibody, you need to confirm with treponemal test. Kasi, tawag dito, pag hindi mo kinonfirm ng treponemal test yung antibody ng RPR at VLDR, pwedeng false negative lang yon sa infection, pregnancy, malignancy, sa autoimmune disease. And then itong mga non-treponemal test naman is used to monitor disease activity fourfold, but may fourfold increase, clinically significant yon. So if positive ka ng RPR at saka VDRL, you need to do the treponemal test, which is your FDA ABS or your fluorescence treponemal antibody absorption. And the others. Itong MHATP, TPHA, and TPPA. So, ang treatment nito is penicillin G. So, pag tatanungin kayo residents, pag penicillin G, ito yung IV type, IV penicillin. So, ang common cause na nito, natanong if you give penicillin G is the Jarek-Sham reaction. So, ang treatment doon is incidented rest. And usually, the patient with primary syphilis may 25% chance na may co-infection to with HIV. So, may high index of suspicion ka rin. I-test for other STDs yung patient. Next, genital ulcers, herpes. So for herpes, HSV1 mainly oral lesions, but accounts siya for 1/2 of first episodes of genital herpes. So ngayon, hindi lang ang HSV1, hindi lang siya pang oral. Kalahati ng mga first episodes na may mukhang herpes sa genitals, pwedeng HSV1. Pero more common ang HSV2 na nagkakos ng genital herpes, mostly seen in women. And HSV2 infection seems to protect against HSV1 infection, but HSV1 gives only a small amount of protection from infection with HSV2. So for pathophysiology, there's replication in epithelial cells at the site of entry, and this damages the cells and it enters the peripheral sensory nerves and nagle-latency na siya sa nerves. So yung natural history nito, nakipagtali ka, and then after 4 to 7 days, you see clusters of erythematous papules and vesicles on the external genitalia. Ayan. Tapos meron siyang usually neural distribution. Ito naman, yung lymphadenopathy tender. Yung kanina, syphilis, non-tender. And then next to 3 weeks, there will be new lesions that will progress to vesicles, pustules, nag-ulcer, nagka-crust, nag-heal. And then this can lead to aseptic meningitis and urinary retention. And tawag dito, if itong ano na ito, itong tawag dito, herpes mo, ito yung causes of painless, hard and raised lesions naman sa ating genitalia. The diagnosis of HSV subtype should be made. And patients with lesions, you get the fluid from the base of the genital lesion and send it for viral culture para malaman ko HSV1 or HSV2. Either you do a PCR or of the HSV DNA. For asymptomatic patients, atypical or healing lesions, you really need to do serology in these patients. Medication, there's no medication to eradicate the virus, only reduce signs and symptoms and prevent new lesions. So how do you treat? You give oral therapy within the first 24 hours of signs and symptoms. You give acyclovir for 100 TID, 7 to 10 days, or acyclovir 200 milligrams 5 times a day for 7 to 10 days. HIV can have prolonged or severe episodes of HIV infection, kaya mas matagal binibigay yung antibiotics pag possible ka na HIV patient ka na may herpes. Next, chancroid. Yung kanina, chancre, yung sa herpes. Ito naman yung chancroid. Chancroid is caused by Haemophilus ducrei. The infection leads to papule that progresses to ulceration and lymphadenitis with progression to buboes formation. Yun yung keyword dyan, buboes formation. And then incubation is 3 to 10 days. And then, eto, makita ninyo na may ulcer siya and then may malaking lymph node dito na mukhang may mga fistulous tract na kung saan-saan. So this differentiates the chancre, which is herpes, to your chancroid. Yung chancroid, usually soft and ragged yung ulcer niya. And then sa chancre sore naman, hard raised and then ano siya, distinct yung border. So dito naman, this diagnosis ng chancroid ninyo is there should be one or more painful ulcer and painful lymphadenopathy typical of a chancroid. And how do you diagnose this? If you have no treponema pallidum on serology or dark field microscopy for at least 7 days after the onset and no HSV. Kasi if you think of that ulcer, hindi mo naman dinadiagnose na yung ulcer itself. You should rule out other disease entity that causes the ulcer. And then, ito daw yung diagnosis niya, if may painful ka na ulcer, painful LAD, and then hindi ka nakita ng treponema pallidum on serology or dark field, and wala ka nakita HSV on your PCR. So the treatment for this is azit 1 gram single dose and the others. So next is your genital ulcers, is your granuloma inguinale. Ito naman, ang keyword dito is your beefy red ulcer, which bleeds easily. So this is caused by Klebsiella granulomatis, also known or formerly called your Calimacobacterium granulomatis. 50-day incubation, ito painless din to, slowly progressive, and then beefy red and highly vascular that bleeds easily. And then, ang diagnosis dito, if may nakita kang visualization ng Donovan bodies, yun yung may arrow, yan, Donovan bodies. And you treat with doxycycline 100 milligrams BID for at least 3 weeks or until the lesions are all healed. So last, yung LGV. This is caused by your chlamydia serovars L1, 2, L3. Ito naman, ang first stage neto is painless self-limited genital ulcer or papule present at the site of infection and nagdi-disappear at the time of presentation. Ang secondary stage neto, magkakaroon na siya ng tender matted lymphadenopathy, inguinal and or femoral, typically isang side lang. And then may fistulous tracts na rin to. And then pag untreated yung LGV mo, lymphogranuloma venereum, it may lead to proctocolitis and elephantiasis of the genitalia. So primary stage, ito yung painless self-limited ulcer or papule, and then magkakaroon ka na ng painful LAD na may fistulous tracts, and then yun. So the diagnosis is culture or direct immunofluorescence or nucleic acid detection. There's no screening available in the diagnosis of LGV. Treatment, Doxy 100, BID for 21 days. So additional readings na lang for the residents are the following: HPV vaccine, scabies, pediculus pubis, molluscum contagiosum, vaginitis, trichomoniasis, and candidiasis. Kasi itong tatlong to common sa female and the rest sa skin. Ang haba sobrang ito eh. TB of the genitourinary tract. Ito, important topic. Your TB of the genitourinary tract is caused by your Mycobacterium tuberculosis complex. Ang mga complex na to consists of the following, yung Africanum bovis and the others. Pero ang tuberculosis and M. africanum lang ang nag-infect ng humans. So, ang epidemiology nito, GU tract is the second most extrapulmonary site after lymph nodes. So, most common site na extrapulmonary is lymph nodes. Pangalawa, GU tract. 2/3 unaffected are usually men, and this is generally disease ng mga tatanda. Transmission nito parang TB, ng pulmonary TB. And then, usually, paano to nagkakaroon ng route papunta sa kidneys natin? Hematogenous. Yun yung principal and primary. Pag ascending or retrograde, mas common to pa nag-irrigate kayo for bladder CA, mga NMIBC natin na non-muscle invasive bladder cancer. If you give your BCG, ang culprit dito, ang isipin nyo is an MBOVIS. Pwedeng hindi siya hematogenous, ascending or retrograde, and others are contagious spread. Pero this is rare or less common. So for clinical manifestations na patient may GUTB, ito, i-explain ko mamaya through IV urography lahat yan. Yung Kershking, mga pipe stem ureter, and the likes. Goldfold ureter and others. So this is an example of your genitourinary tract TB, which I will dwell on more. So for the clinical manifestations nito, most common site is the kidney for your GUTB. Kasi ang GUTB mo may infect the bladder also, the urethra, and the others. Pero most common na infect ng GUTB is the kidney. Seen in patient with lung TB with renal failure. And the biopsy reveals granulomas. Pag full-blown renal GUTB ka na, this is a miliary type of GUTB with scattered milia seeds on the cortex and the medulla. Granulomas can cascade and form cavities that cause pyelonephritis necrosis. And end stage neto, kung hindi na-treat ang GUTB sa kidney, is autonephrectomy, which cause the kidney to be non-functioning. So ito yung nakikita ng clinical manifestations naman sa ureter. There's fusion of multiple strictures that may create a long, irregular, several non-confluent strictures na magkakosya ng beaded or corkscrew ureter. So pansinin niyo dito, para tong corkscrew, yung itsura ng ureter natin sa patients na may GUTB na may associated thickening, mucosal thickening ng ureter. So it may also cause a pipe stem ureter, parang pipe stem ng pipe. So, nagsistem siya. So, ito yung pipe, may stem, ganon. Rigid ureter, may magkakaroon ito ng irregular and lax normal peristaltic movement with fibrotic strictures noted. And note na may distortion, amputation, and irregularity of the upper pole calyces. Sa bladder naman, ang manifestation nito, syempre waterfall effect. Most common kidney. Kung may GUTB ka sa kidney, possible ka magkaroon ng GUTB sa ureter and pababa. Bladder. Sa bladder naman, ang early stage nito, patchy cystitis or ulceration. And pag tinanong kayo, ang most commonly affected ng GUTB ninyo sa bladder is the dome. Trigone and neck, usually normal. In this image, we can see the IVU ng man with renal tuberculosis na nagkaroon ng waterfall effect sa bladder, nagkaroon ng irregularity sa lumen due to mucosal edema irritation. And then, kung late stage na to, magiging thimble bladder. Ibig sabihin ng parang thimble bladder, yung ito, thimble, yan. So, ayan, contracted na yung bladder. And usually, yung patient nito, low capacity na yung bladder nito pag late stage na. So, for the GUTB sa epididymis naman, ito yung second most common site ng GUTB. And ang root nito, usually, hematogenous. So, most common site ng GUTB, kidney. Second most common, epididymis. Pareho sila, hematogenous. Bilateral to in 30% ng patients. And may granulomatous formation din ito. And ang nakikita sa PE is a nodular epididymis, which is swollen and hard. And mind you, if you have a epididymal TB, it may extend to the testes. And it may make testicular tumors. So, again, yung sa ibang GUTB naman, sa prostate, pwedeng via hematogenous or via urinary contamination. However, this rarely causes abscess, but nakikita na may abscess sa iba sa patients na may AIDS. SEMVES, cause infertility, yung GUTB sa SEMVES. Granulomatous sa walls ng seminal vesicles with lumen cassation. Sa urethra may happen, pero mababang percentage lang. Pero kung predisposed ka, kung meron kang prostatic GUTB rin. So sa penis naman, palabas na tayo. Penile TB, pwede ka magkaroon ng inflamed papillary or keratotic plaque, also known as lupus vulgaris. Marami to. Sa skin lesions, mapapansin niyo, mga pemphigus vulgaris and the likes. So ito, yung tawag dito is lupus vulgaris. It's ulcerate and spreads in the cavernous to cavernous tissue, and the penis is usually the lesion is usually painless, hard, and similar to malignancy. And the fibrosis may lead to penile distortion. The diagnosis for GUTB, urine AFB culture, gold standard. And then, yung iba, pwede rin, yung LJ tsaka yung MGIT. Pero pag tinanong kayo, at saka yung NATS, pero usually not used, ang gold standard dito is urine AFB culture. For the IDU naman, imaging, ito yung gold standard for early renal TB. Most common findings nito, yung nasasabi ko kanina. Pero ang cause nun is secondary to obstruction, result ng scarring and distortion of the collecting system. So for your IV urography naman ng kidney, may kita dito isang moth-eaten appearance ng kidney. Pansinin niyo yung leaf na to, parang kinain siya ng moth. So yun din yung nakikita dito sa IVU ng kidney. Ito yung nagpe-present ng normal calyces, pero ito magkakaroon ng indistinct feathery outline dito. Tsaka dito. And then also it can cause phantom calyx. Yung parang wala pero meron talaga siyang calyx. So there's the decreased nephrogrammic capacity in the non-filling or collecting system. Elements of the lower pole in this kidney. Phantom calyces, meaning parang ghost, pero it exists but not visualized. Sa ureter, beaded and corkscrew ureter, na-discuss ko kanina, inner pipes ng ureter. And dito, sa insertion ng ureter, pelvis, nagkakaroon ng kink, cur kink. Ito. There's a kinking of the renal pelvis at the UPJ. Excuse me. So CT urogram, most frequently used in developing countries, similar findings na makita sa IVU. So makita rin yung mga pipes ng ureter, moth-eaten, ganyan, mga cur kink and everything. Tandaan nyo lahat yung mga words dahil tinatanong sa interviews. So for if you do cystoscopy in the patient naman, if usually ito nakikita nito mga ulcers, and then you can also see that the ureteral orifice looks like a golf pool. For the medical treatment, standard short course pa rin, 6 months na 2HRZ, 4HR yung binibigay. So intensive and continuation or the maintenance phase. Okay, hindi ko na i-discuss yun. Surgical therapy. 55% of patients with GUTB will require surgical management due to the course of their disease. So kung may suspecting ka ng GUTB sa patient, you give the patient medical therapy. Pero kung meron ng parts na mukhang kailangan mo ng operan yung patient, you should think na you should always preserve the kidney as much as possible. Ang principle lang ng pag-opera mo is to relieve urinary obstruction, drain mo yung infected material, i-remove mo yung non-working or infected kidneys, or improve mo yung medically resistant hypertension, secondary to functionally excluded kidney, and reconstruct the urinary tract. So yung may example nito, pyeloplasty, UU, and the likes. Cystoplasty or augmentation cystoplasty, palitan mo na lang yung bladder, mga ganon. Basta as much kailangan mo i-preserve yung urinary function ng patient. So for special situation, pag pregnant yung patient o breastfeeding, you should treat GUTB immediately. Tatandaan nyo the risk of the fetus from TB outweighs the risk of the adverse drug effects. So usually binibigay dito HRZE for 9 months daw, but pyrazinamide is exchanged with pyridoxine. Kasi pyrazinamide daw is toxic. And then yung patient may breastfeed postpartum. Pag may immunocompromised ka, you treat TB, of course, longer. Additional readings for the residents naman is the Schistosoma, Filaria, Echinococcus, and nasabi ko na pala Echinococcus, Enterobiasis, and Amoebiasis. So that's all. Haba.
Mic check. Test.
Sobrang haba.
So thank you for that very, very, very comprehensive lecture, Dr. Sergio. If you have any questions, you can turn on the mic now or put your questions in the chat box. But I think one question earlier from Dr. Tan. So the question was, as far as I can, what are the instances, aside from the indications earlier, that you acute nephritis? So it was mentioned earlier. So you can or uncomplicated, and you admit if it's very ill. Also, yes, for
Sorry, wait. Ayan, okay. Hindi kita marinig eh.
answer. Do you want to expound your question earlier, sir? I summarized the indications for admission. Yes. Right there. Sir? Can somebody hear me? Hello?
Ilagay yun ni Sid sa slide niya. Whether you give it orally or parenterally. What is the main indication, usual indication, that you na yung pinaka-reason bakit you have to admit a patient having acute pyelonephritis? Ano yung parang pinaka...
Okay, so for the residents who wants to answer that question, so what's the... Ernest, you want to answer that? Why would you admit? What's your indication for admission usually?
I think, sir, if there are present comorbidities, like for example, pag diabetic yung patients or other cardiac diseases, mga ganun, sir.
Sige, give me another answer, Ryan. Naka-mute ka.
Another indication would be if, for example, the infection, the acute pyelonephritis the infection is high, and the patient is warranted for an IV antibiotics for at least 3 days. So we wanted the patient to be admitted.
Okay. Actually, bakit siya kailangan ng IV antibiotics? Di ba sabi ko nga, pareho lang naman ang bioavailability ng most antibiotics even if you give them orally. Nandun na, nasa IV na. Bakit?
Yes, because sir, for IV antibiotics kasi sir, diretso po yung transmission niya compared to an oral. Usually, there is a first pass effect pa, sir.
Hindi nga, bioavailability. We're talking about
Bioavailability.
bioavailability. So,
Bioavailability.
yung level lang sa serum is the same.
Baka yung absorption, sir.
Ano pa? Ralph?
Ano sir, regarding yung bakit IV?
Oo.
Sir, hindi ko pa yata nababasa yun.
Hello? Sir, can I answer your question?
Sige, go ahead.
So there are two lines of thought. So in our guidelines, we may give IV or orally, although it's the same for any medications. That the bioavailability between oral and IV medications is the same, but at the same time, if you plan it, you may give first note.
Salamat din, sir.
However, if you're giving IV antibiotics, it's different. So you may give ceftriaxone, gentamicin, depending on what you're treating. But at the same time, above all, before seeing your patients, you anticipate sepsis. So that's why you give antibiotics, you admit your patient. And also, to add to that, some patients, they don't religiously take the medications. That's why you have to admit. Also, if you're for what Ernest had said, for diabetics and also solitary kidneys, you may admit them regardless of their status, just to anticipate your sepsis. So it's different with oral and IV. Because hindi naman, like for example, ceftriaxone or third generation ceftriaxone, it's not everything is available already.
Okay. Sige, actually, may point naman lahat ng sinabi nyo. What I'm driving at is, isa lang naman yung talagang parang pag nagkakaroon ng severe. Na-mention niya yun eh, yung, hindi ko alam kung na-mention niya doon sa slide, na if the patient has intractable na yung parang suka siya ng suka. So hindi na siya maka-intake ng food. So baliwala yung oral antibiotics. So hindi na absorb. So much better if you admit the patient and then give IV antibiotics. Yun lang, ganun lang kasimple yung hinahanap ko. Pero yeah, yes, you have your point. Pero yun lang yung ano ko.
So we have another question. So this is from Dr. Matias about the asymptomatic CAUTI. So how do you differentiate it from asymptomatic bacteriuria? So by definition, CAUTI, it's catheter associated. Sir, do you want to elaborate on your question? Dr. Matias?
Hello. Kasi ang sabi doon asymptomatic CAUTI from what I recall kasi if it's CAUTI, you categorize it as CAUTI because the patient already has symptoms. So technically, pag sinabi mong CAUTI, you have bacteriuria but the patient has symptoms. So nagtataka ako, what is asymptomatic CAUTI? Did you find that somewhere? Baka hindi ako updated. So clear ba? Sorry. Clear ba? Hello?
Clear,
Yes,
sir.
sir. Clear naman, sir.
So from what I read in Campbell 11, most catheter-associated UTI may be asymptomatic. So it's probably an overlap. You can have...
Tama yan. Bacteria tawag doon. Asymptomatic bacteria ang tawag doon. Kasi pag sinabi mong asymptomatic bacteria, you have a culture-proven bacteria, meaning you have a culture positive na urine which shows bacteria. So the difference between bacteriuria and CAUTI is that CAUTI has symptoms, meaning patient has fever, patient has flank pain, suprapubic pain. Kaya siya sinabing catheter-associated urinary tract infection. You have symptoms of infection. So pag walang symptoms, ang thinking ko doon, from what I've read before, that's a symptomatic bacteria only. So yun lang, ano lang yan, semantics eh. Pero that's how I recall it when I read Campbell. So baka mayroong updates na hindi ko nabasa. Kaya nagtataka ako when it was written there, asymptomatic CAUTI.
Okay, noted, sir. Do you want to elaborate that, Dr. Sergio? So point taken for that. So we have another question from Dr. Tirol about HPV. It manifests. He mentioned that it manifests around 4 to 7 days after intercourse. If the individual has intercourse every day, will he still be asymptomatic? Medyo hindi ko gets yung question, but manifest 4 to 7 days. Sir, Dr. Sherry, do you want to comment on this question? Hindi ko masyadong gets yung question, sir. But I think what he's trying to say, what's the relationship between the manifestation or the incubation period on having HPV. So I think same then, sir, if regardless your still manifests as 4 to 7 days. So regardless from the time of contact, from when you had your contact, and then you start the count from 4 to 7 days of incubation period. I hope I answered that question correctly. I understood that question. So if we don't have any more questions, Thank you, Dr. Sergio, again for that comprehensive lecture. And we have a gift from our intern, so good luck to you. So we invited you since this is maybe part of your board exam. So if we don't have any questions, we may adjourn. Thank you, everyone.
Group picture muna. Screen on.
Copy.
Screen on na lang lahat.
Best. You know, or me, oh, yun.
Ay! Relax na relax. Paano ba maglagay ng ganyan, Carl? Yung may mukha na lang na steady.
Hey! Pag may account ka na ata niyan, Hermie.
Ano, sir? Kailangan may account.
Hindi ko rin alam
may app?
Pag join meeting ka lang, wala eh.
Ano, H.
Okay na po.
Kailangan mayaman. Wala nagbilang.
Okay na po, okay na.
Alright, thank you.
Thank you. Tomorrow, 9 p.m. po. Topic is urinary reconstruction.
All right.
Okay, thank you.
Okay, thank you. Bye-bye. Thank you.
Thank you.